Ladies and gentlemen, welcome to this edition of the Cameroon Town Hall for Healthcare Professionals, yet another rendezvous today. I'm very glad to see all of you already tuning while we wait for others to join us. Today is going to be a very exciting session. Once again, just to remind those who might be joining for the first time, the Cameroon Town Hall for Healthcare Professionals is a platform that brings together healthcare professionals from Cameroon origin spread around the world and to discuss issues relating to health in the country. And last 2 weeks ago, we celebrated the first anniversary of this great initiative, and it was really great. We were very glad to get very positive feedback from all those who have been able to attend the town hall with very great suggestions. And we hope that we are going to make the town hall a better place to serve all of you, to make sure that we come here every fortnight to talk about the health of our people back home. Today is going to be an exciting edition because we have brought a very big hand in the house to discuss a very important topic, which you will soon discover. But of course, based on your suggestions last time, we will try as much as possible to make our town hall a very inclusive place. And of course, let me hand the floor to Christelle. Christelle, you want to say hello?
Thank you, Elvis. Hello to everyone. Welcome once more, and hope everyone enjoyed the weekend. Thank you.
Thank you very much. And I'll be co-hosting with Dr. Bama and Dr. Bama Solange and Luisa Viban and Brian Tegomo. Today we do not have our own Alison. She's very busy and could not join us today. But of course, we are going to have Dr. Solange Bama, who is going to serve us in the French language. Dr. Solange, bonjour, bonjour ou bonsoir. Can we have Solange? All right, then I'll continue to do it with Christelle. Christelle, you want to tell us something in French?
Okay, while Solange is coming in, bonsoir, bonjour à chacun d'entre nous et bienvenue à cette édition bilingue de Cameroon Town Hall.
Thank you very much. And Luisa, you want to say hello?
Hello, Elvis. Hello, everyone. Welcome once more to another edition of the Cameroon Town Hall. As you can all see, we've grown. We're 1 year older, and now we are bilingual. So this is really great. And thank you all for your suggestions in making the town hall better. And I always look forward to every town hall, and I'm really always privileged to co-moderate every session with you all, the team, and thanks to our chairperson, Dr. Foma, for everything you do. Thank you, Elvis.
Great. And Brian, you want to say hello before we hand the floor to Muno for updates?
Oh, it's always a great honor to be with everyone. Welcome, everyone. We are 1 year old, so it's a great honor to have everyone on board today. Looking forward to this session.
Great. And this session is truly going to be an exciting one because we are going to have a very renowned cardiologist in the house who is going to serve us with really some good stuff. But before we get to that level, let us get the updates on COVID-19. Dr. Muno, what's happening?
Okay. Elvis, thank you very much. And truly it's a pleasure always joining the town hall, each and every session, and being with you guys. So today, and I know you guys are going to introduce my friend here, but I would like to say, so it's just something more personal than anything else. Dr. Tucker and I, we've gone for over our whole life. And since when we're young in high school, in the secondary school,
Your line is breaking up, Muno. There might be a connection challenge with Dr. Muno. While we wait for Dr. Muno, Christelle, vous pouvez quand même rappeler notre frère et sœur l'objectif du Cameroon Town Hall? Peut-être pour les gens qui sont ici pour la première fois.
OK. Bienvenue une fois de plus à Cameroon Town Hall pour la présentation d'aujourd'hui. Cameroon Town Hall, c'est une plateforme qui regroupe les différentes professions médicales originaires du Cameroun dans le pays et ailleurs pour échanger sur les pathologies communes et l'expertise de chacun dans un domaine bien précis, et aussi a pour but de créer un réseautage entre les différents participants pour améliorer non seulement les conditions de santé dans notre pays, mais aussi de s'améliorer tant dans la recherche que dans l'emploi. Hope I've been faithful.
Merci beaucoup, Christelle. Et à vous, Dr. Mono.
Yeah, so thank you, everybody, and sorry for my connections. It's quite, so I'm very glad and happy to have Dr. Taka here with us. We were fortunately or unfortunately posted out of, when we left medical school, we were posted together in Bamenda Regional Hospital where we worked together, and before he moved to the US. And when I moved here, he was the first person who actually took me in and has been instrumental in I getting some kind of a career here in the US. And it's a pleasure to have him here with us today. So without saying much, I would just like to say we do remember this. The pandemic actually is getting better globally. Even the surge in India is actually getting better. These are the different strategies we talked about from the beginning, what we think could be done in order to help the situation. I know a lot of us did minimize the COVID pandemic, but right now we've had over 200 million cases of COVID-19 in the world. And this has been a serious pandemic, and things are getting better in the West. And we're still trying to make sure that places like Africa, we don't get surges because we have not had enough cases there. So if you look at it, the pandemic is actually getting really bad in the South Americas, and India is getting better this week. You could see here that the number of cases globally is actually reducing. India, the trend in India is falling. India has become the second largest country with a pandemic after the US. These are the global numbers. We're getting almost to reaching almost 200 million cases of COVID-19. Here, this tells us there is some hope. India was crying for help, and a lot of countries have actually gone in to help India, and they have donated vaccines. I hope this same initiative goes into Africa. And the US is having a different kind of problem. They are having vaccines and not having enough people to get them. So here we could see the number in India. The past 2 weeks, we have had about additional 2 million cases in India. The number of deaths also have actually increased. Cameroon has also had about additional 100,000 cases, and the number of deaths have not been that bad. So the pandemic is actually slowing down in Cameroon. Here you could see the first and second wave of the pandemic, which is a good thing. Now we also see the death rates in Cameroon are reducing, which is also good. The vaccination uptake is actually not as good as we want to. You could see the different regions. There is a lot of vaccine hesitancy, and I think we have a lot of experts on that here in the platform who can help back home, like Professor Wisonge, there is Allison, there are others who have been talking about this since the beginning. So you could see the second dose, a lot of regions are lacking back. The central region and the extreme north are the ones doing quite well. You do see here in the map that we do still have some areas, both in the Adamawa area and also the northwest and southwest region due to the conflict, where they have not been able to even give a single dose of the vaccine. South Africa still triumphs other countries in Africa with a number of cases. And the US is still the peak of the pandemic, though the cases are reducing. And we can see that this is no longer a try and error thing. No few drugs have given doses to 2 billion people. So we have had 2 billion shots of the COVID-19 vaccine given worldwide. You could see here that Africa is still having some kind of distribution of the vaccine, and availability in Africa is still very low. And there is still uneven access to vaccination when you look at it worldwide. The richer countries get all the vaccine, the poorer countries are fighting and struggling to get it. And when will life return to normal? The US was on track, but things are getting worse. And really, the 3 months have become 6 months before the US can actually get back to real opening normal, but they did open all the economy. Cameroon, on the other hand, would take 10 years if we continue at this same vaccination rate in order to prevent the transmission from occurring. go to European Union, you think 4 months, and are we really bending the curve? It's getting to our realization that not all vaccines are equal, but that's going to be a debate of another day. You see the Israel, they did vaccinate about, by the time they get to 75% of their coverage, the number of cases have drastically dropped to almost zero. They are not having any COVID cases anymore. Then you go over to looking at other places like the United Kingdom, the number of cases are also low. You're having the new variants. The names of the variants have been changed to Alpha, Gamma, Beta, Lambda. India complained about people using India as a variant. China did complain. UK did not mind about it, but the names have been changed by WHO. So we're going to get used to that as time goes on. Looking at the case in the US, we could see here that the number of cases also are dropping. Vaccines are working. If you look at the Shizl, I did look and update at it again, depending on they are still having high cases and the numbers are still coming up despite their vaccination rate of 70%. The question is what kind of vaccine are they getting? Chile, on the other hand, is still having high cases and number of cases are increasing. If you look at where Cameroon is, we're really at the bottom of coverage for vaccination and we need to do something about it before we have a third surge. Morocco is still the highest country in Africa with the highest number of vaccination rate of 21%. So you do see here that the US actually has about 700 million doses of vaccines available. So they need to start sharing the vaccines. We all know about the different vaccine platforms that are available out there. I'm not going to spend time talking about this. There is still vaccine hesitancy available in the US. We could see that more people are getting ready to take these vaccines. And there are several incentivizing campaigns that are being done. There's lottery, others are feeling that they got the vaccine and now others are being paid to get this vaccine or they are being incentivized to get the vaccine. Some crazy states like Virginia, West Virginia, offering guns and trucks and also to those who get vaccines. So they're doing everything to make sure people actually get vaccinated. There is also issues with this, minimal support from government vaccination mandates. There have been mandates about vaccinations, but actually what we are realizing is that most governments have not mandated any form of vaccination, which is good. Certification programs, which some thought were going to pick up, but this is not really what is happening, which is a good thing. People are not able to certify before actually returning to work. This may be done in the private sector. What I think here, we need broad adaptation of passport by government, highly unlikely, which is a good thing. Government prohibitions on private certification programs is also unlikely. So private sectors in Europe and in the US would decide what they want to do. And now already people back home, some of them cannot travel to certain countries without actually being vaccinated. So without the rate of vaccination has actually slowed down significantly in the West, especially in the US and in Europe. So while Africans are actually lacking vaccination. So certain other areas have had or taken into account certain strategies in order to increase their vaccination uptake. So there are other strategies I think Africa needs to learn from this to incentivize people to get vaccination, but there are worries that come to this because people will start asking questions. Do we need to incentivize people to get vaccination? Does it mean these vaccines don't really work? And there are potential concerns that always come in terms if you try to do this and continue doing this over and over again. So we know that several vaccines are available in Africa. Something is better than nothing. In Cameroon, we do have the AstraZeneca, which is available. And we also do have the Pushnik vaccine right now, which is available in Cameroon. And I know a lot of people who have taken that. It's available through the private sector. You do have the Sinopharm, which is available. And please, it's always going to be important to advocate for people to get vaccinated and for us to be as transparent as possible to tell them what the side effects are going to be and to look out for those side effects. In terms of therapeutics, not much has changed in terms of COVID therapeutics. The drugs that are available, we do know hydroxychloroquine doesn't work, and this was withdrawn from the Cameroon protocol. We do know that there are certain things that work. Dexamethasone does work. We know convalescent plasma may help. We know that monoclonal antibodies do help. We know that combining baricitinib and remdesivir would help. We do know that treating ourselves out of the pandemic is going to be difficult. So vaccinating ourselves out of it, testing ourselves out of it, preventing the disease, as every other public health strategy, prevention is better than cure. In the outpatients, not much has also been developed in recent times. You do have the monoclonal antibodies, which are not available in most countries in Africa. They are expensive. They are very efficacious, but very expensive in the first place. So at the moment, I think what strategy we need to do, our take-home message back home is that we should try as much as possible to prevent this disease. Now we have time, now that we have had the second wave and the things are calming down, for us to vaccinate everyone, get them vaccinated, stop the pandemic, and prevent ourselves from becoming the next India. So my advice to everyone sitting here who is involved in politics is for us to continue talking about this vaccination rates, the efficacy as I show here in this slide. It's very efficacious. The number of cases now, my hospital used to have so many cases, we're having few or no cases. Most of those coming in are those who are vaccinated. You do have breakout cases in 1 in a million case of those who get vaccinated. So especially those who get the Pfizer and the Moderna vaccine. So guys, I think that is it for now. We knew these variants through the names of countries, but now we start, I'm confused also with the names. I don't know which is Alpha, which is Beta, which is Lambda, which is Delta. But I think vaccination is a key to getting us out of this pandemic. Thank you, Elvis, and over.
Thank you very much, Dr. Mono, for always putting this very rich package. Sometimes I don't bother reading a lot of emails I get at my work with updates because I know Mono is going to tell me in 2 weeks' time. Thank you so much for always doing this, and we really appreciate your time in putting these updates together. And at this point in time, I would want to disclose the topic of today. Luisa, why are we here today? What are we going to be talking about?
Okay, so the time has come. Today we're going to be listening to one of our top specialists who is going to be telling us about heart attacks. Is it the hidden pandemic in Cameroon or in Africa? I know that when the pandemic started, everyone was like, oh, we're talking about COVID, it's not in Africa. Let's deal with what is in our own country or what is in our own continent. Do we know if we actually have heart attacks, how many heart attacks we have, and what to do if we encounter someone with a heart attack? So today we are really privileged to have Dr. Taka, who I will not spend much time talking about. I would just in here, so we'll learn more about him.
Yes.
Sorry, I get an echo.
Yeah.
Is it okay now?
It's okay.
All right, thank you. Okay, so without taking much time, Dr. Taka is going to really tell us about everything we need to know about heart attacks. It's going to be hot. So get your water, get your coffee, and get ready. Thank you.
Thank you, Luisa. And maybe Brian, can you tell us who Dr. Taka is? I know you know him so well. That's why I decided that you present him too.
I just want to say that it's we are truly honored to have Dr. Takang with us today. Dr. Taka is a cardiologist. He's an interventional cardiologist in advanced endovascular cardiology. He recently completed his fellowship in interventional cardiology at the University of Kentucky in Bowling Green, which is one of the most phenomenal places where you can ever do cardiovascular medicine in the United States. And he completed his fellowship also in cardiovascular disease at the University of Mississippi Medical Center in Jackson, down there in Mississippi. He finished his residency at Grady Memorial Hospital in Atlanta, where he served as the chief resident during his senior year. And prior to his residency, he had worked in Cameroon with Dr. Mono, as Dr. Mono mentioned earlier. He worked in several hospitals in Bamenda, in the extreme north. And so he's been one of us. He's been part of the CAMESA team as well. He's been one of us in the family. He's board certified in internal medicine, board certified in cardiovascular disease and interventional cardiology. He's a member of multiple professional organizations, including the American Heart Association, the American College of Physicians. He's also a part of the Cameroon Medical Council, our own local professional board of medicine in Cameroon. He's also a fellow of the Society Society for Cardiovascular Angiography and Intervention, which is a hallmark for excellence among interventional cardiologists. The Society for Cardiovascular Angiography and Interventions, the SCAI, is the primary professional association for invasive interventional cardiologists and physicians and who diagnose and treat cardiovascular disease and congenital and structural heart diseases or conditions through catheter-based procedures and angioplasty and things like that. So we are really truly honored to have you here, Dr. Takan. We're looking forward to hearing more about your about heart attacks and the hidden pandemic in Cameroon and in Africa. It's truly an honor for us to have you here today. And I'll turn it over to Solange, who will make a brief presentation about Dr. Takan in French.
Over to you, Solange. You want to unmute?
Bonsoir à tout le monde. Je m'excuse, je n'ai pas pu me connecter un peu plus tôt. Je ne sais pas si j'ai ce qu'il faut pour pouvoir introduire Dr. Takan, mais je vais faire de mon mieux en résumant juste pour dire que Dr. Takan est cardiologue. Il a fait de la cardiologie interventionnelle et endovasculaire avancée. Il a fait sa formation de cardiologie interventionnelle à l'université de Kentucky à Bowling Green. Il est également spécialiste en maladies cardiovasculaires qu'il a fait au centre médical de l'Université du Mississippi à Jackson. Le docteur Takan a terminé sa spécialisation au Grandi Memorial Hospital d'Atlanta, où il a été résident en chef pendant la dernière année de son cycle de spécialisation. Avant cela, il a travaillé au Cameroun dans les régions du nord, de l'extrême nord, pardon, et du nord-ouest à Babinda. Il est certifié en médecine interne, en maladies cardiovasculaires. Il est membre de plusieurs organisations, dont la American Heart Association, American College of Physicians et aussi l'Ordre national des médecins du Cameroun, qui est notre association propre à nous. J'espère que j'ai vraiment été fidèle et je n'ai rien dit. Merci beaucoup.
Merci beaucoup, Christelle. Et maintenant, à vous, Dr. Takan. À vous le micro.
Well, thank you all so much. That was very generous and kind. I am flattered. I am blushing. I lack the words to express how honored I am to have been given this opportunity to discuss a topic which is very close to my heart. From the get-go, I'm going to say that, I think this topic is very important. Mostly because I guess a bunch of us here are out of the country, and sometimes I really worry that if my grandmom shows up with a heart attack, or if my uncle shows up with a heart attack, whether or not they would be diagnosed. Is this an issue that we so often miss in terms of posing the right diagnosis in Cameroon, or is this an issue that simply does not exist? Is it truly a hidden pandemic? So that's kind of what I'm going to be talking about today. I'm going to share my screen. If you all just bear with me, give me a second. Let's see, heart attack. Oh, hold on, this one. That's the right one. Right, so our topic today is going to be heart attack, the hidden pandemic. Can you all see my screen?
We do.
Yeah, we can see your screen, but not the first slide.
I actually cannot see my screen. Okay, give me a second.
Great.
Let's see if this works again.
Oh yeah, beautiful.
Okay, there we go. So heart attack, the hidden pandemic in Cameroon. So before we delve in this topic, I realize that not everyone here has a background in cardiovascular diseases, or not everyone here might be a physician. So let me just lay the groundwork to begin with. So this presentation is going to be short and sweet. I have approximately 20 slides. The whole idea is for me to lay the groundwork and ask a few questions, and open up to answer any questions you all have. And hopefully together we can learn from each other and we can make a meaningful impact to the care provided to our families back home. So just to lay the ground, the foundation here, cardiovascular diseases, what does that mean? It's just an umbrella term that encapsulates all diseases that affect the heart and the vessels. It's that simple. So heart and vessels. So the two main branches is heart disease, right? And heart disease has three main subcategories. So ischemic heart disease is what we're going to be talking about today. You also have valvular heart disease and hypertensive heart disease. So ischemic heart disease just means blockages in the heart arteries, all right? And then on the other hand, the second category is the vessels in the body, so peripheral vascular disease. So if you have a blockage in the blood vessels in your brain, that's what we call a stroke. If you have that in your lungs, that's what we call a pulmonary embolism, etc., etc. So it's just cardiovascular disease is just an umbrella term. I'm going to come back to this later when I'm talking about cardiovascular disease in Cameroon. So this is just meant to establish these definitions before we delve into the topic in detail. So, you know, when Dr. Forma first asked me to talk about this topic, the very first thing that came to my mind was Bamenda Regional Hospital. Now, believe it or not, I was in this hospital for about 2 years, I think, and I never once diagnosed anyone with a heart attack. Now, I am very sure that I'm not the only one with this experience, and I'm sure that this is not the only hospital that has the problems we face when we work there. But, you know, you don't know what you can't see, and you can't see what you don't know. Both statements are true. You know, I recall one evening when I was on call at the regional hospital, and this lady came with acid reflux, but it was a weird kind of acid reflux. You know, this was like 2 a.m. and she showed up, and she was like, this lady was maybe in her 50s or 60s. I still remember this vividly, like it was yesterday. And she came in, she was like, well, she's had acid reflux before, but this is something else. Something is wrong, you know. She feels like she's going to die. She doesn't know exactly what's happening. Very, very strange. I examined her and I do everything I could, but everything was normal, you know. Now, the one thing I did not do for sure is I did not get an EKG. So guess what? The EKG machine was locked up in the director's office. And that's where that EKG machine stayed for most of the time, you know. During the day, the director would read, the director at the time was an internist. So he would read the EKGs during the day, but at night, no one had access to the EKG machine. The other thing is that, well, during the day, pretty much he and the tech, they were the people who had the most access to the EKG machines. And I think one other physician was allowed to read EKGs. So getting EKGs was a completely foreign concept to me at the time. And again, I bet that in many hospitals in Cameroon, maybe not the big hospitals in Yaoundé and Douala, but I bet in most rural hospitals in Cameroon, most of the hospitals where our families reside, they may not have access to this basic but critical and crucial technology. So the question, therefore, is, during my 2 years in Cameroon, is it just that I did not see heart attacks because they did not exist, or because I didn't see them because I didn't know? That reminds me of the a story, the Emperor Has No Clothes. The first person who told me this story was my dad when I was much younger. It's a story, for those who don't know the story, it's a story of a mean emperor who he summoned all his tailors and asked them to fashion him a garment that no other person in the entire empire has. So that was a task. Get me a garment that no one in the entire empire has. And they had 24 hours to do that. Now, if you came with a garment that some other person had, you get assassinated. So the next day, all the tailors showed up, you know, and he killed them one after the other because each of them showed up with garments that some other person had made before. And then there was this tailor who walked up with his empty hands, so to speak, and everyone was surprised. And the tailor said, well, you know, Mr. Emperor, yeah, I bring with me a garment that no one in the entire empire has, because this garment is invisible to all your enemies and is visible to all your allies, right? So as soon as he said that, everyone else in the room said, well, we can see the garment, it's so beautiful. So the king was amazed. The emperor was like, wow, I have a garment that is invisible to my enemies and visible to all my friends. So this garment does not exist. So he takes the garment, He takes off his clothes, obviously. He goes to the royal chambers, takes off his clothes, puts on the garment, and then goes out and is walking the streets. And everyone is excited about his new quote unquote garment. Till one kid, you know, kids sometimes can't hold their mouths and they are brutally honest. So this kid walks up and he screams at the top of his voice, "The emperor has no clothes." So then the emperor realized that he was walking around naked, you know. So you cannot know what you cannot see, and you cannot see what you don't know. And obviously any resemblance this cartoon bears with any real life personalities is purely incidental. So you don't know what you cannot see. So in Cameroon, is it just that these cases don't exist, or we actually don't know how to diagnose them? That's the big question. So let's look at the data. Let's look at what we have. So remember at the beginning, I talked about cardiovascular disease. So cardiovascular disease is an umbrella term that includes heart disease on the one hand and vascular disease on the other hand, right? And within heart disease, you have heart attack, so ischemic heart disease, right? So let's see what information we have so far. So this is information from 2013. You have a prevalence of 4.7% in Cameroon, right, of cardiovascular disease. And you can see the comparison with the death, the mortality, which is disproportionately high. So it's one of those diseases that may not be as prevalent as infectious diseases, but when you compare to the mortality, see, you have a mortality of 11.6% for 4.7%. And when I look at this data, I immediately question it, because what bothers me is when we talk about cardiovascular diseases in Cameroon, what are we referring to, and how do we make this diagnosis, you know? So I went through a bunch of information, a bunch of journals, and I found this is actually the most recent data I found. This is from 2020. This is April 2020. This is barely a year ago. Now notice that when they report mortality for cardiovascular disease, it just provides information for cardiovascular disease. Now there's no granular information about what kind of cardiovascular disease we're talking about. Are we talking about ischemic heart disease, right? Are we talking about vascular disease, you know? So we don't have that provided in detail. At least we have a little bit of information about rheumatic heart disease. So rheumatic heart disease is a valvular heart disease. It's the second subcategory I showed you all when I was talking about cardiac disease. You know, so we really don't have any information about ischemic heart disease, right? So that begs the question as to whether these cases simply do not exist, or we're just not making the diagnosis, you know. So I sort of looked at other countries in sub-Saharan Africa to give me some pointers as to what the situation could be in Cameroon. So as you can see here, these are a bunch of countries in sub-Saharan Africa, and this is a collection of so this is pretty much cardiovascular disease, right? And you have here in this bar chart, and you have here, what you have here in blue, right, represents ischemic heart disease, specifically what we're trying to talk about today. And that ranges from about 25% to a quarter, so 25% to 50%. So worst case scenario, we expect that about 50% of cardiovascular disease should be ischemic heart disease, right? So think about that, right? I just showed you all that about 12% of mortality related to cardiovascular disease. And I'm telling you the next slide that, well, it looks like, based on the information we have in other African countries, it looks like about 50% of all cardiovascular disease should be expected to be, so 25 to 50% should be expected to be ischemic heart disease. We don't have that information reported at all in Cameroon, which makes me the more believe that we are missing a bunch of patients who are potentially dying from ischemic heart disease. This is information from the United States amongst Blacks, which is the closest thing we have to reflect or to represent Africans out of Africa. So if you look, I just want to highlight a few things here. So you see, this is B, A and B. So these two represent ages greater than 50% combined. So you have a mortality of somewhere between 23 and 31% for ages greater than 50. And this is for males, Black males, and then you have that for Black females, very close to that number. So after looking at all the data, I came to the inescapable conclusion that more than likely what is happening in Cameroon is we're actually missing a bunch of people who show up with ischemic heart disease. Now, it might be because you have this old lady who presents with acid reflux and you're like, well, this is just acid reflux, and you put them on Pepsi and then they go home and then they suffer with that for a couple of months and eventually pass. Or it might be because it is this diabetic lady who presents with shortness of breath, and you say, you know what, this is probably due to pneumonia or something, and you put them on antibiotics and send them home, you know. It's all these typical and atypical presentations of ischemic heart disease that makes it very confusing, and even the more makes it important for us to have objective means of making this diagnosis and recognizing these patients who present with ischemic heart disease. So when we talk about ischemic heart disease, there are two things we're referring to. So again, ischemic heart disease just means blockages in the heart arteries. This could be something that has been there for a long time. That's what we call stable ischemic heart disease. Or it could be something that has been there for a long time, but then changes all of a sudden. So for instance, a person walks in and says, well, I've been having this chest pain, predictable with exertion, you know, but all of a sudden yesterday I started having this chest pain at rest. That would make you worry that this might be a heart attack. So when you have a sudden change in symptoms, which is acute, of course, that would make one worry about a heart attack. Now, this is what I just explained in pictures, right? So blockages in the heart arteries, that's what ischemic heart disease is all about. So you can have a severe fixed blockage in the heart artery, right? So because you have the heart is a muscle, right? And for the heart to beat, the heart needs a steady blood supply. So if you partially block the heart artery, what happens is that the muscle hurts because it demands this blood and it cannot have blood at the time it's needed. So then you get this chest pain with a certain amount of exertion, right? And that should not be confused with the more acute setting, which is what we call a heart attack. So there are two types of heart attacks. So basically, a heart attack occurs when that blockage, what we call plaque, right? That blockage ruptures and you have a blood clot in the blood vessel. So it's a sudden rupture. You have a blood clot in the blood vessel. So that leads to chest pain, which is sudden and at rest. So there are two types of heart attacks. You have the heart attack that occurs when there's a blood clot, which just partially blocks the vessel. And you have a heart attack that occurs when the vessel is completely blocked. Now, both cases of heart attacks are considered as emergencies. Again, I think this is a very crucial point to clarify before I go into how we can recognize these things and what we can do in Cameroon to better recognize these different types of ischemic heart diseases. So again, on the one hand, you have stable ischemic heart disease, which just means that it's a stable blockage, a stable plaque that stays there, right? And every time you exert yourself, you predictably have symptoms. It could be shortness of breath, it could be acid reflux, it could be chest pain, right? And on the other hand, you have a heart attack where you have these symptoms occurring now at rest or with minimal exertion. It's all of a sudden. And this could be a partial blockage or complete blockage. So all of these are actually important, you know. One of the other things which are cardinal in making the diagnosis of important in recognizing a heart attack is the EKG, something as simple as the EKG. Now, this is not a cardiology lecture, so I'm not going to go on defining EKG criteria for heart attacks, but the bottom line is when you have changes in certain parts of the EKG, ST segment changes as we call them, you know, even more important is dynamic changes, meaning that the patient walks in, you do the first EKG, and you do a second EKG, even if you don't know how to interpret EKGs, but you notice that between the first EKG and the second EKG, there are changes, right? That would be highly suggestive of a heart attack in the right setting. So first cardinal means of recognizing heart attack is the symptom. Second is the EKG, and the third is the troponin. So when after the blood vessel gets blocked and the heart cells, the heart tissue gets injured, the next thing that happens is the heart spills out these molecules, which are called troponins, right? And this can be directly tested in the blood. So three important things: EKG, troponin, and then the last thing I'll talk about is angiography, right? Now, I do realize that some of these things are not readily available in Cameroon, but that's the whole reason why we're having this discussion, to figure out what aspects or what elements of diagnosis do we have readily available, and is this just a problem of limited resources, or it's a problem of a lack of an understanding of how these limited resources can be used. So, can we afford an appropriate diagnosis in Cameroon, and can we afford appropriate treatment? I think this is the core of this presentation, and I'll attempt to answer these questions to the best of my ability, and hopefully answer any questions you guys have. So let's talk about what tools we have in our toolbox to diagnose heart attacks. So, and let's look at how effective these are. So I'm going to start off with the EKG. All right, let's forget about the MRI and angiography there for a second. So let's look at the EKG, right? So if you are following the strict criteria for EKG, so standard criteria for EKG, right? You know what you're doing, you're following strict criteria. The sensitivity of the EKG drops down significantly, right? But specificity goes up dramatically. So what I can tell you is that if you understand the strict criteria for diagnosing a heart attack on an EKG and you do see it, you're more than likely correct in terms of your diagnosis. Now, on the other hand, if you're not looking at strict criteria, you're just looking at any change you see in the EKG, the sensitivity goes up to above 80%. You know, so the EKG, depending on how you use it, is actually a very, very good tool. You're talking about 80%, depending on how you use it for sensitivity, and above 80%, 90-something% for specificity if you're using the strict criteria. So it's a pretty good tool. Now, troponin is actually quite good as well. As one slide I left out here is the high sensitivity troponin, which has a specificity, has a sensitivity actually of above 90%. I'm going to briefly talk about coronary angiography. Coronary angiography is the gold standard for diagnosing heart attack. And I understand that getting coronary angiographies readily available to different places in Cameroon is probably not going to happen anytime soon. But for the sake of this discussion, I'm going to go on and just describe what this is all about. So, of course, a heart attack refers to blockage in the heart artery. So, logically, the way to relieve that would entail some form of unblocking the heart artery, either doing that mechanically or doing that with medicines. Now, in this case, doing a heart catheterization or coronary angiography is a procedure where we mechanically try to unblock the vessel. So this is how it looks like for anyone who has never seen this done before. How it's done is we go through one of the blood vessels. So all the blood vessels connect to the heart. We go in with a tube, we call it catheter. And when we get to the heart, we inject dye, and then all the vessels in the heart light up, as you can see here, right? And here you can see one of the main vessels is blocked up here. And then this is before and this is after. So we go in with the equipment, clean out this vessel nicely, and put in a stent. So that's approximately, this is in a nutshell how it looks like. And this pretty much fixes the problem of a heart attack. So doing a heart catheterization has two advantages. One is it gives you a definitive diagnosis, and two, it enables you to fix the problem, right? So what about treatment? In most places around the world, there are algorithms for treating heart attacks. or acute blocked heart arteries. And I just put this slide here to highlight the things which should be done and the mortality benefit. And we'll think about, every time we'll think about whether these things can be done in Cameroon, right? So first thing to be done, according to the guidelines in the United States, whether you're African American or not, is get aspirin. So the studies, bunch of studies have been done and showed that a single tablet of 81 milligrams of aspirin makes a difference in terms of outcome. Of course, this is assuming that it is recognized that this is a heart attack. Just 81 milligrams of aspirin, something as simple as that. Now, if you only just have a suspicion of a heart attack, the patient is having sudden onset, chest pain, shortness of breath, or acid reflux, to name a few, sometimes just nausea, right? Which is just something about it is just abnormal. You know, it's not the regular acid reflux you'd expect. First step, 81 milligrams of aspirin. The second thing is to do an EKG. I cannot emphasize how important getting an EKG is. It's a very simple tool, it's very cheap, but for what it's worth, an EKG is actually very critical in determining and treating and diagnosing patients with heart attacks. The next step is getting an EKG. Right? And then there's all these criteria for the EKG and all of that. I'm not going to go into that in detail. Then you make the diagnosis, right? What we recommend is getting an EKG, repeating the EKG 10 minutes later, and seeing if you have any changes, all right? And if you have any changes, then you should be highly suspicious that something is going on, especially when the patient has the symptoms. And then the next step is troponins. I think I went one slide too fast there. Is getting troponins. Now, I can imagine that if I went to MADA or certain places in Marwa, I would not expect to have troponins done in most labs. So troponin might be a little bit of a challenge, but troponin is not an indispensable tool in diagnosing heart attacks, and EKG is. So that's a major difference. So the simple tools we have so far in terms of treatment is 81 milligrams of aspirin, a single tablet of aspirin, and getting an EKG. Now let's go further down the line. Now, when we establish that this is in fact a heart attack, what other options do we have in terms of treatment? Two main options here. Again, it's a heart attack, the vessel is blocked. We have to figure out how to unblock this vessel. If there is no cath lab, there is no ability to do a coronary angiogram and to put in a stent, the next option is to pharmacologically unblock the vessel. This is what we call thrombolysis. Now, the question is whether we have this capability in Cameroon, and the answer is a resounding yes. So thrombolysis just entails the injection of a medicine, a thrombolytic medicine, which would help break down this clot. And I'm going to show in a bit the data comparing early thrombolysis versus actually doing an angiogram and putting in a stent. Anything beyond this is just medical therapy, you know, giving low molecular weight heparin and oxaparin, which we have in Cameroon, giving beta blockers and giving ACE inhibitors. So just looking at this chart, you can immediately see that we can make a huge impact in terms of diagnosing heart attack and almost effectively treating heart attack with just minimal, non-expensive, available equipment in most places in Cameroon. Now, this is a slide that compares TPA versus angioplasty. This is actually the CAPTIM study. It was done a while ago, but it's a very good study because this study is still cited in the American Journal of Cardiology to date. And it's looking at overall survival in two groups of people. The group above in the discontinued line above is the patients who got thrombolysis. So these are people living in rural areas and they don't have a cath lab, or the cath lab is too far off, and so they give them thrombolysis, versus the people who delayed, right, and they had to take them to cath labs. And what they found out was that the survival was actually very good with thrombolysis, you know. There's been this debate, I mean, in many countries, developed countries, including the United States, on how quick patients with heart attacks be taken to the cath lab to get the blockage mechanically unblocked. So angiography and stenting. And what this study showed is that 2 hours is kind of what the cutoff is. So thrombolysis and PCI are kind of comparable, right? Less than 2 hours. From the time the patient actually has a heart attack, if you can push a thrombolytic agent, right, then you are doing immeasurable, you're doing a lot of help in terms of improving their mortality over 5 years, 1 year, and 1 month. So there's a significant difference versus just doing nothing. So you can see here in this D column, thrombolysis versus PCI, 2 hours and greater than 2 hours. So this is very, very important to understand. You don't necessarily need a fancy cath lab to make a difference in terms of saving the lives of your patients. So that was for heart attacks. Now, what about stable coronary artery disease? Remember when I started, I showed one on the one hand where you had that stable plaque, unruptured plaque, right? And on the other hand, you had that ruptured plaque with the thrombus. So let's talk about that stable plaque. So now, in this case, this is not a heart attack, but this is a heart attack waiting to happen. And the reason I thought it was important to talk about this is because I think it would make a bigger impact in terms of life expectancy, mortality, and all of that in Cameroon if we focus on diagnosing these cases early. So for you to have a plaque rupture, you should have a plaque in the first place. That's the logic. So if you can figure out the patients who already have stable coronary artery disease, then you can start putting them on medicine to prevent them from having a heart attack. So that's the whole idea of stress testing. Stress testing is a means that we kind of stress patients' hearts and see how they behave. If they start behaving like they're about to have a heart attack, then that tells us that they're at risk of developing a heart attack in the future. Now, the different modalities of stress testing is the echo stress test. For that, you need to have an echography machine. Those are increasingly more available in Cameroon. You have a nuclear stress test, which is I understand requires a lot more technology. You need to get technetium, it's kind of a radioactive substance and all of that. It's a lot more sensitive and specific. It's just in a resource-limited country, it's just difficult to have these available in most hospitals. And then you have an EKG stress test, right? Which only requires an EKG machine and a treadmill, right? Let's look at how these different stress tests perform compared to each other. So here you have the exercise electrocardiogram, which is what I talked about, the EKG stress test. It has a sensitivity of about 68% and a specificity of 77%, which is not bad at all. I think this is fairly good. It's not the best. It obviously does not compare to the SPECT, for instance, or the PET, but it's something. I think it would make a significant difference if we can use this in resource-limited areas. And this again just entails all you need is a treadmill, which we have rampant in Cameroon, and a computer. That's all you need. All right. So the ultimate question is, how do we bridge the gap? To make the diagnosis of coronary artery disease and a heart attack, we need simple tools like EKG and troponin, especially the EKG. If this piece of equipment could be vulgarized, then I'm pretty confident that even in resource-limited areas, even in my village, we should be able to make the diagnosis of a heart attack. The next question is whether we have protocols in place, and whether, even if we have these protocols, every physician would have a basic understanding of how this protocol should work and how to interpret these EKGs. The next thing is a troponin, which is also very critical. I'm not quite sure how available this is and whether the labs in Cameroon can frequently test for troponins, but it's something that I'll be interested in knowing what everyone thinks. And of course, for stable coronary artery disease, prevention is better than cure, as I mentioned before, an EKG stress test All we need is a treadmill and a computer. And we should be able to weed out these patients who potentially can have heart attacks in the future and prevent them by putting them on adequate medical therapy. Okay, I am done and I'm going to take questions.
Wow, that was amazing. Thank you so much, Dr. Taka, for this presentation. It's so hard to see how you can take a complex issue and try to make it as easy as you have done, such that one can even, be able to feel like a cardiologist in his own neighborhood. Thank you so much for presenting this topic in a way that really is palatable to most of the people here. That's my opinion. I'm sure many might share the same opinion. And it's such a great opportunity that we have today to have you. Now it's time for us to get to questions, and I'm sure a lot of people will be having some questions. As usual, if you want to ask a question, just indicate by a show of your finger and you'll be given the chance or the opportunity to ask your question. And to our French brothers and sisters, please feel free to ask your question in your language. Feel free to ask your question in French, and if Dr. Takan cannot answer you in French, he will answer in English, but I'm sure you will get something. Feel free to speak your own language that you're comfortable with. Once again, Dr. Taka, thank you so much for this presentation. And now we just want to set the tone with the questions and to ask you, if you are in a rural setting, take for example, in somewhere far off in the Northwest region in Misaje, and you are the medical doctor there, or say maybe the head nurse, and you have the luxury of having an EKG machine, which maybe somebody from which CRISPR from Japan donated to you, and you are able to diagnose that this person has an EKG or is about to have a heart attack. What, apart from just the medical, the medication approach and not the mechanical approach, which you suggested to see how to dislodge the clot, how feasible is it for you to stabilize that patient in Misaje, considering that the distance between Misaje to Shisong Hospital would take you like 5 hours? Will you suggest referral or local management? Should we focus on quick referral to what this can be taken care of, or should we spend more time training people at local level to diagnose and take care of the situation?
Well, thank you so much. That's an excellent question, Elvis. So there's been a lot of data on what you just asked, and the answer is a resounding yes. I would lean more towards training the local physicians and nurses to manage these patients who show up with heart attacks. I would recommend getting a protocol, right? So it's going to be a protocol, chest pain protocol. You go with the EKG, and then the very next thing, of course, 81 milligrams of aspirin, which I talked about, and then thrombolytic therapy. There's going to be a standard protocol, standard doses. And so everyone just knows that if you have 1, 2, 3, this is what you get. Now, even in the United States, there's such a thing as first medical contact to balloon time. And it's that 2-hour cutoff that we look at, and that's because we found out that, it's not worth it delaying. If you know that you cannot get to a cath lab within 2 hours, right? You lose that mortality benefit from mechanically open the artery compared to just giving a thrombolytic agent. So kind of what is recommended even in the United States is, in that particular context, you want to go with the thrombolytic therapy. And it does really well. I mean, I think we're kind of spoiled with so much technology that we have nowadays that we forget that there are things that still work. And this is one of the things. I think just if you can stock your local pharmacy with thrombolytic agents, and you have a standard protocol, you have your aspirin, you have your metoprolol, just basic medicines, that would go a long way.
Yeah, thank you so much. Ndika, your question, please.
Yeah, thank you, Dr. Taka, for the presentation. That was beautiful. Oh, I just wanted to, it's not a question, I just wanted to piggyback on what Dr. Taka has said. You know, he mentioned that they should have protocols. Yes, that is very important. And it's very important for you to actually diagnose and know what exactly you're dealing with. Because somebody can come to the clinic and tell you have a chest pain and they give you medication for pain. I've heard that a lot of times. Because if you don't know exactly what you're dealing with, you misdiagnose the patient and send the patient home. You know, and also I live in Los Angeles, California, and you have something what is called continuous medical education. I think that is something that should be implemented in regions like this. I went to Cameroon, you know, talked to a few people that work them, asking them what is what do you exactly do for the doctors to make sure that they are up to date with their practice? Because medicine is a practice, Dr. Taka. You can attest to that. If you don't, some people have seen malaria 10,000 times, but they haven't been in a situation whereby somebody who is diabetic comes in with a presentation of a heart attack, and they're not used to that. They'll definitely do what? Send them home. So in a nutshell, I think, number one, the protocol is very important. Somebody who has a heart attack, this is what you have to do. You give them, well, you can give them morphine, oxygen, nitroglycerin, aspirin, something that is standardized. Where you go to Shishong, that's what Shishong is going to do. You come to Limbe, that's what Limbe is going to do. We don't have protocols like that. You know, so I don't think it's a question, but it's just something that I just want to piggyback on what Dr. Taka presentation is all about. And I really appreciate you having this presentation for today. Thank you.
Thank you so much, Dika, and thank you for tuning in from Los Angeles. Crispo, Dr. Crispo, how is Japan today?
Oh, thank you. It's good. Sunday morning. Thank you, Dr. Taka, for your presentation. I really have a bunch of worries, though. I'm gonna try to, I don't know how to put it, four-pronged manner, but the first one is regarding troponins and BNP. So I don't know exactly which one you can advise on first instance in terms of someone who has an acute myocardial infarction or someone who has a chronic heart disease. So, and then the second branch is concerning PCI. I mean, you said we could use thrombolytic agents or drugs if we were, say, in a very rural setting in a country like Cameroon. But usually we take, for instance, someone who is class 2, for instance, or class 2, class 3 New York Heart classification. And they have to go a couple of blocks and then they have to sit and wait for their hearts. In such cases, how would you advise for someone who's working back home to manage that kind of person, that kind of patient? Because I don't really think we're habilitated in doing PCIs. And do you think usually with our diets too, that giving just a thrombolytic agent will really help the patient in long term? Or, you know, it's just to save them at that time for them not to die, and maybe they have to look for a way to Shisong with something like that. And then the third one is regarding using ACE inhibitors and beta blockers. Again, I'm always a little bit worried about these two medications. When is the best time to use which one?
Good questions. Can you repeat your first question again? I was kind of like got carried away by the second and third. What was your first concern?
The first one, it was with regard to troponin and BNP.
Good. Let me handle that first. So troponin by far. So there are two, and this I'm getting a little bit technical. Sorry, but there are two subsets of troponin: the troponin T and troponin I. Right, both of them are actually quite good. What we have now is the high sensitivity troponin, and the cutoff to be considered positive troponin is based on every individual lab. It has to be there's a bunch of criteria. Now, I think where people get confused is there are patients who walk around with elevated troponins, you know, You can have end-stage renal disease, there are a bunch of things. You're very hypertensive, you have LVH, I can go on and list a bunch. But, very specifically in the setting of a heart attack, the main difference is you're going to see a rise and a fall in the troponin, right? That's very important. Matter of fact, the ACC defines it as a 25 to 30% rise within the first 3 to 6 hours. You have to see a rise and a fall. So that describes a pattern of ongoing injury. That's kind of different. So it's more of a dynamic picture. You have to take it in context. So yes, by far, a troponin is a very important tool, but I would argue that is not nearly as important as an EKG, right?
Okay.
And then your second question, what was your second question?
Second question is PCI.
Right, and thrombolysis. So the idea of doing thrombolysis is to do it as soon as possible. All right. If you had, take the example that Elvis gave. You have Shesong, which is 5 hours away, and Shesong has a cath lab and they have the capability of doing PCI. Now, when they did the study, right, there are a bunch of studies. There's Gusto, Timothy, there are a bunch of studies they've done that looked at this. Is a CAPTIM study, which was actually done in France, a very good study. So what it kind of did was they said, okay, let's give thrombolysis, right? Let's push the medicine, right, early enough, and then there's a time delay, whatever time that is, then we send them for PCI, we send them for angiography and stenting, right? And when they did that, they saw that the patients actually did better overall. So it's actually better to push that medicine, right? And then take your sweet time. Well, not really take your time, but you can now arrange for transportation to get them to a facility that can perform PCI. Now, in this case, it's referred to as rescue PCI. These are things which have actually been studied in detail, So yes, so TPA, that would be my go-to. So thrombolysis, and then you refer. Now, in terms of long-term, the most important thing about coronary heart disease or ischemic heart disease is preventing plaque rupture. Remember, I showed that slide where you had a stable plaque and you had a plaque that ruptured. So if you can find a way to stabilize the plaques and prevent them from rupturing, then in the future you prevent a second heart attack, right? So when you give thrombolysis, what you're immediately trying to do, or when you put in a stent, what you're immediately trying to do is you're trying to clear out that blood clot and you're trying to restore flow. But beyond that, you have to take measures to prevent another plaque or that same plaque from rupturing, right? And that's why you have to put patients on medicines, especially statin therapy. So the Jupiter trial was done several years ago, and that showed a more than 40% reduction in recurrence of heart attacks or in recurrence of ruptured plaques when you put them on a high-intensity statin. So those are all technical details, but all these things are very nicely described in literature and previous studies. So again, it comes back to the whole thing about protocols. If we all know, and these are all things we have available in Cameroon, if we can all establish a pattern of behavior in most of our hospitals where we know that in the acute setting, here's what we give, and then before the patient leaves the hospital, here's what we give to prevent this from happening again in the future. I don't know if I answered your question.
Yeah, thanks. Just the last one on ACE inhibitors and beta blockers.
Oh yeah, thank you. So the only absolute contraindication for ACE inhibitor is bilateral renal artery stenosis. That's the only absolute contraindication, aside allergies, of course. But really, ACE inhibitors are such a fundamentally necessary medicine. And kind of in the setting of a heart attack, right, there's certain contexts where ACE inhibitors are really critical. But more importantly, the ACE inhibitor it helps the heart to recover, because when you have the heart attack, there's a damage to the heart muscle. And so putting the patient on an ACE inhibitor actually helps them recover. Of course, short of having those two main contraindications I talked about, you should pretty much feel comfortable prescribing ACE inhibitors to these patients.
All right, very well. Thank you so much.
Thank you so much. We have many questions coming in, and Muna, you want to come in with your question?
Yeah. So, Dr. Tak, I want to put things into perspective. really, because you have spoken a lot about several things, and I want to take you back to our days. We were posted together, and we're posted in one of the biggest hospitals in Cameroon. First thing is, concerning our training, do you think we were trained enough to feel that heart attack is a priority? Do you think, I know we're trained on heart attack, but do you think while leaving school, we thought this was prevalent? This is a priority in medicine. People die more from heart attacks than from any other thing. Do you think we're ready? Back in 2008, when we're in the regional hospital running things, both you and I, we took almost all the calls. That's when Dr. Are left for school, Dr. Ayub left. We're both of us taking care of these patients. I know one day you were about doing an EKG and I was making fun of you. This is reality. The second thing I want to ask you, how many, I know recently, L'Hôpital Général in Yaoundé, those who are working there can own up, and EKG is not available in their emergency unit, meaning it's not part in no hospital in Cameroon. I think we need to go back to fundamentals, meaning in no hospital or few hospitals, maybe like Cantini, I had seen one there, where EKGs are done as a fit or sick vital sign parameters to those who get in and those who may be complaining of chest pain, no matter the origin, and females who may be complaining of GERD. This is something which is lacking. I was posted to as a director of a hospital in Cameroon. I could buy an EKG machine. Elvis knows that I could buy an EKG machine for $500,000 because I had a budget I was running. Did I not buy it because I didn't know, or was it my training, or was it prioritization? Third thing, you spoke about doing troponins. Are our labs even able to do it? How long will it take for them to run a troponin test and give it to us? Can we trend it? Are we even going to be able, are we trained in such a way that we can get these results out, doctors look at them and be able to actually see a troponin rise and fall? Are we able to start giving patients heparin? Can we put them on a heparin drip and do a PTT in order not to cause them to bleed in the future? Are we ready to be able to even start, once we diagnose this patient, to put them, let's say we can use Lovenox, as you said. I loved your presentation because it was simple. It was trying to give hope, but I think that we lack the basis of diagnosing. I think that we lack the orientation back in school to orientate the students that this is a priority. I think that we need to go to the drawing board and start talking about these basic things. You have made it seem so lovingly. I know you are not here to condemn your country in any way, but you've made it look like something we can do. I'm not talking about PCIs you do every day. You do that every day as an interventional cardiologist. I'm talking about basic things that can be structured right from our schools and orientate our medical students to know that this could be a problem. The prevalence could change if we're looking for it. We are not even looking for it. I did not look for it throughout the time I was in Bamenda. It's sad, but that's the truth. I did not look at it. Even during the time I was a clinical pathologist, no one sent us. I did clinical pathology in QS, in CHU. I tested troponin, little or no time. There was no time troponin was sent to us in the lab to test it in the whole of CHU. Can you believe that? I worked there as a pathologist. So it's just a reflection. I wanted to steam up this discussion and get back to the basics, Dr. Taka. So I know I'm going, so you can take over, please.
Thank you, Muno, for asking the question and imposing the answer inside the question. Dr. Taka, you're on the hotspot now.
Yeah, no, thank you very much. I think that's the whole idea. That's the whole reason why I did this presentation in the first place. Because, again, I started off by saying that, most of us, a bunch of us are out of Cameroon, and our parents and our relatives are back there. And you don't want a situation where your mother goes to the hospital and has a heart attack and it's trivialized and she's sent back home, I'm just going to answer a few questions amongst the questions you asked. So I acknowledge the fact that I think from a purely practical standpoint, if we're talking about making troponins available, in all hospitals or in most hospitals in Cameroon, I don't think that Cameroon will be able to accomplish that. Well, can we make it available or readily available in big hospitals like CSU and most other big hospitals in the provinces or in the regions? Yes, possibly. But what about an EKG? You know, what about an EKG? This is very, very simple. And guess what? You do not need an EKG. You do not need troponin to diagnose a STEMI, what we call a STEMI, meaning the vessel is completely blocked. You actually do not need a troponin. All you need is an EKG, right? You do not need a troponin to see that the EKG is beginning to change, right? You had the STs looking this way, 5 minutes later, it's looking dramatically different, 5 minutes later, it's looking dramatically different. And this patient is obviously having some chest discomfort that she has never had before. You do not need a troponin to make that diagnosis. You know, a troponin is a crutch we can use, but it is not indispensable. So I guess my point is, we do have the tools available in Cameroon. I don't think that's where the disconnect is. As Dr. Mona put it, is it a problem of, are we just not considering this a priority when we're training our medical students? You know, are we just in the different hospitals? And I would like you all to give your perspectives, especially those who have worked in the system or those who currently work in the system. Is it just that we don't think it's a problem? Is it just that culture that we think that, well, everything has to be infectious disease? I know a bunch of these things, a bunch of infectious diseases in Cameroon, but is it just something we don't care about, or what exactly is happening? Or are we just lacking in protocols, right? My personal opinion is that heart attacks is seriously trivialized in Cameroon, and many people die from sudden deaths. I bet there are lots of people here who know at least one person who has died from a sudden death. 80% of the time someone dies from a sudden death is from the heart. It's a heart attack or a consequence of a heart attack. Now you have stroke and you have pulmonary embolism, but 80% of the time, if you heard that someone in Cameroon dropped dead, it was a heart attack. So I am fairly certain that is a problem which is being trivialized and missed. The question obviously is, how do we fix it? How do we take it from here? Yeah.
Alison, you have a question for Dr. Taka.
Thanks, Dr. Taka. This was a very interesting presentation. So just two thoughts or thoughts. I think the first thing is the acute nature in which, the heart attack ideally should be handled. Many of our patients come to the hospital long after the heart attack had happened, and they had sat at home. They didn't even know they were having a heart attack. And when they come in so late, even if you have the resources to diagnose it, is there anything else that can be done for these patients? So I guess that's the first thing. The second thing is, even for patients who think they can recognize it, we don't have ambulances home that would carry a patient from their home to the hospital, like on time, to have the interventions that need to be done. Because maybe there's traffic, or even if they had a car getting home, it's complex. So even when they get to the hospital, the process of, like, from the point of entry into the health system, going through or standing on the queue to buy a hospital book, getting registered, getting on the queue to see a doctor. We don't have systems that really take prioritization of healthcare of patients seriously. How can all these health systems related barriers be overcome? And then I guess the third comment is just, so I remember my days in school, reading an ECG for me initially was very challenging. I remember we had, after studying so hard and sharing notes, and you spend, I think in internal medicine rotations, ECG reading was one of those things that took me like forever to even grasp, because you have to practice, and the cardiologist will tell you, no, you need to look at many ECGs to be able to pick it. And then the 1 second you pick one and you're excited, you think you've picked it, and he's like, no, this is an artifact. This is just because of the blood pressure. You're like, are you kidding me? So my question is, with all the evolution in technology, are there like available tools that you know of that can facilitate this process of reading an EKG for healthcare providers? Thank you.
Excellent questions. Excellent questions. So let me start off with the barriers to getting to the hospital. So those barriers in Cameroon are barriers that exist everywhere. I'll start off by saying that if a patient presents to you in a hospital with chest pain, and that chest pain is due to a heart attack, it means the heart attack is still ongoing. It also means that at the very time you're seeing that patient, whatever you do is going to improve that patient's possibility of surviving. So far as that patient shows up in the hospital with chest pain, there is still something you can do. All right. Now, about the person who lives somewhere in Dapang, far inside Pinyin, and it will take them 1 hour to get to Santa or 2 hours to get to Santa and then chest pain. I understand that. You know, those are things that we can probably not get around because that would involve fixing the infrastructure and all of that. Now, I really wish there was a robust ambulance system, a medical ambulance system in Cameroon, even in Yaoundé. Unfortunately, we don't have that. So, I mean, I'm curious to know what every other person thinks here. But what I can say is, if that patient shows up in the hospital with chest pain, the person is still having ongoing chest pain. That is, the person is still having an ongoing heart attack. So you can still do a lot of good there. Now, in terms of EKGs and making diagnosis, yeah. So I kind of understand the complexity of interpreting an EKG, you know, but I make the distinction in my mind when I'm giving these talks. I make that distinction of having that finesse of identifying, well, is this a posterior STEMI? Is it an anterior? Is it a right-sided and all that stuff? No, we're not expecting the physician to, a non-cardiology physician, to make those diagnoses. What we are expecting them to identify is obvious signs of a bad heart attack, like a STEMI. Those things, you are not going to miss them. You see the ones that ST segments are yay high. Yeah, you can't miss them. The other thing I talk and I insisted on is dynamic changes. You know, you would always not miss dynamic changes, even if you don't know what you're looking at. Even if you think you're looking at squiggly lines, you're going to see the squiggly lines change. You know, there are very few things that do that in the world of cardiology, and heart attack is one of them, right? Matter of fact, most of the time it's going to be a heart attack. Now, the third thing I'll talk about is echoes, handheld echoes. Now, that is the technology I think is going to take over the market, even in Africa. You know, I think it's going to get very rampant. Now, it turns out that when so remember I said that the heart is a muscle and it squeezes like this, right? If the artery supplying this part of the wall is blocked, this part of the wall is not going to squeeze. The other parts are going to squeeze. And just by putting an echo probe on the person's chest, you can tell clearly that this is a heart attack happening. I think these echo machines, they're getting, the handheld ones they're getting available. And I think at some point, I imagine in the future, these things will be readily available in many hospitals in Cameroon. So I think those tools can kind of help, you know, but there are problems in Cameroon I don't think we can get around, like you mentioned initially. I don't know if I answered your questions.
Yeah, thank you, Brian. And Brian will bring Dr. Kate. Dr. Valerie, sorry.
Yeah, and Dr. Taka, I really love that analogy with the emperor, that you can't diagnose what you don't know if you don't have the right diagnostic tools. And I also love that graph that you shared with the specificity for the different diagnostic platforms for myocardial infarction. And I saw the difference for the specificity and sensitivity for the troponins. The specificity was pretty good. I think it was in the 80s or 90s, and the sensitivity was pretty low. And I would you mentioned that given the kinetic nature of troponins and how that changes over time, I would guess that the positive predictive value of every troponin assay would probably be increasing with time. So I wanted to start off this conversation. I mean, since we are all here and we have Dr. Kendry, who has spent a lot of time in diagnostics, are you seeing a lot of point of care testing for troponins? The challenge with EKGs, and one of the things I'm hesitating around EKGs is even if we have EKGs donated to every hospital, there's still a challenge with interpreting what an EKG is. You might need to, have a snapshot of that and send that to a cardiologist to interpret, and not all physicians really do recognize what a stem elevation looks like on an EKG. So we still have that challenge, even if we have that machine being donated to all hospitals. And we are fortunate in the United States that with the advent of data science and the tools of data and machine learning algorithms and things like that, you can use we are still able to use machine learning algorithms to interpret an EKG without really necessarily you having to have a cardiologist. So for it's kind of a point of care testing, and I'm hoping that that kind of innovation is going to come go over the wall, and we will be able to have we will be able to have, you have an immediate interpretation for your EKG and things like that. But that's still lacking. We still don't have that in Cameroon. We still don't have that in Africa. So I wanted to get your thoughts around this point of care testing. Are you seeing that in the United States? And can we have point of care testing for I'm thinking more about troponins. And I mean, 1-point measurement is not going to really tell you a lot. We probably need to have a serial measurement, serial testing over time. And I guess the predictive value will probably increase, or the specificity will kind of increase over time. But wanted to get your thoughts on around this idea, these diagnostics. How do we identify what we are not seeing and all that? Thanks.
Right. Let me chip in before I let Kenji answer the rest of the question. So, the problem with over-reliance on troponins is a troponin leak does not diagnose an acute myocardial infarction. I need to clarify that over and over. The only tool, the single most important tool, is an EKG. Now, we don't have EKGs readily available. That's correct. But I think that is something that can be fixed, right? 2, we do not have folks, as you rightly mentioned, physicians who are readily available to interpret EKGs. Now, I tell you what, most of the medical students I work with, they're able to identify a STEMI. So it's not a problem. It's not a problem of people, except if you want to tell me that physicians in Cameroon just simply don't have that ability. Of course they do. I think it's a problem of priority, it's a problem of training, because a STEMI is as easy as it gets for most of the time. I mean, there's that rare posterior STEMI that everyone is going to miss, including most of the ER physicians we have in the United States, all right? There's that rare right-sided STEMI that a bunch of people are going to miss, and you need a cardiologist to make that diagnosis. Granted, but for the vast majority of acute severe heart attacks, it's really obvious. I think physicians are fully capable in Cameroon of making this diagnosis. If we have this continuous training and they have adequate exposure on how to make this diagnosis, an EKG is really an indispensable tool. About point of care testing, we do have that in most emergency rooms in the United States, but I'm not able to provide you with details as to the sensitivity and specificity and all that cool stuff.
So Dr. Taka can answer that a bit, and maybe Kenji can. So we do have point of care. I will just go from my pathology test. We have point of care troponins, which we stopped using in my hospital. Reason we stopped was because the regular troponin that we got it early. We got it on time back in my hospital, and we missed a lot of cases with the point of care. The point of care is just like a glucometer you measure, and you're able to get the glucose reading. But we got the troponin readings within 15 minutes back using a spectrophotometer. So there was really no reason doing the point of care anymore, because it was not really very helpful in the sense that we could miss some cases of NSTEMI, meaning non-ST segment elevated myocardial infarction. Those when you look at the troponins. But as Dr. Tucker said, the EKG is very fundamental in this diagnosis. And I think a lot of these machines, even coming from China, do have the algorithm to do a read.
Yes, and just not to cut you, I wanted to show you this without any publicity. This is an EKG machine that I have here, and this one has a capacity to tell you, the diagnosis directly without you spending time to interpret. There are those major diagnoses that can be picked up. I think this can actually tell you that this is a STEMI or this is this. It's really, and these are actually very easy, portable, and you can extract the data even on by internet, and just like a cardiogram, and send it to your physician by email to give an interpretation. That's why there is need for also technology, to incorporate technology and see how you can make use of experts that are far off to do these interpretations too. Yes, Kenji. you have to talk about.
And I just wanted to tell Brian one thing. In the absence of maybe situations where we could get a troponin to be measured in the lab, those point of cares can be used in third world countries to help solidify the diagnosis. But I don't think in the US it's going to replace everything that we're doing. So over to you, Kenji, sorry.
Yeah, I can chip in a bit on point of care troponin after Kenji. It's Terence here.
Oh, okay. Hi, Terence. So I'll just be brief so Terence can come in. I think that's his thing. In the US system, we have point of care testing, but even for us too, we have a core lab, where we run stats. So if it's an emergency, they just collect the sample, they use the PTO, it comes to the core lab, and we just use like the Roche line or any line and run it, which is more sensitive as compared to the point of care test. So that's one thing too. To the best of my knowledge, I know SD Bioline has like a stick, just like the malaria rapid diagnostic test for troponin. And they claim a sensitivity of about, I think, 97% or so. I think it's better to use it than nothing at all in Cameroon. I think one of the challenges in Cameroon is that most of the proprietors or most of the people that run the hospitals care so much about malaria, right? Because, ordering for troponin and all the like is not something that is commonly done. So they probably don't see the need to investigate to see that, hey, even SD Bioline has a stick. You just run it like malaria RDT, and within 15 minutes, you can have a result. I think it measures up to 0.5 nanograms per mil. I mean, it's not so much the best, but I think it's better than nothing. So this was just for those that are in Cameroon. If you are thinking of bringing in troponin, you must not bring the big analyzers. There's still that cassette. And as I always say, it's always good to run these validations before implementing it, right? We don't just get the things from Bioline and we just start implementing. So it's good to just run a validation study in comparison with the spectrophotometer and actually assess the sensitivity of the rapid diagnostic testing before implementing it in Cameroon. Over to you, my brother.
Okay, thank you, Kenji, for that response. Thank you, Dr. Taka, for that very, very good presentation and a very short presentation, but with a lot of knowledge in it. So with respect to troponin, I had to ask this question to say something about this before I had a small incident at home and left. So I hope nobody said, I'm not going to repeat what someone said earlier. So there are point of care troponins out there. So Kenji mentioned one manufacturer, and then also Abbott has what they call the iStat, which also it actually compares very better with the conventional troponin assay, which is only leaving the US hospitals recently because of the high sensitivity troponin, which you mentioned. And I do cover some remote sites here in Canada, in Alberta, in the Northwest Territories, and even in rural Alberta, which don't have troponin in their major lab analyzers. And they do use this point of care troponin. I mean, they use them a little bit differently, where you go there if there is a rise in troponin against what the validated cutoff. Sorry, my video was up there. Against the validated cutoff, they then transfer the patient to the bigger hospitals. In our case, I think either troponin or an ECG, both of them could act complementary. In those places, like you remember the incident where you mentioned that in the Bamenda Regional Hospital, there was that night that the ECG machine was locked up in the director's hospital. In that case, if there was a troponin, then that would have at least assisted you in diagnosis. And you know this better than I do, that in cases in women, myocardial infarction actually presents a little bit different in terms of symptoms than in men. So in such cases, using a point of care troponin, which is relatively cheaper. I mean, like the cost of the test here is like less than $1. I know going to Africa, the cost might be higher, but I don't think we could actually replace that cost with the cost of the life. So yes, there are point of care troponin. They are not as sensitive as the major ones, the lab, the ones which are measured in the big lab analyzers, not as sensitive as a high sensitivity troponin, but they compare relatively better with the conventional assays. And then another thing which could also be done to assist in the sensitivity would be doing a small local clinical validation with the physicians there. So you know that, okay, using this cutoff indicated by the manufacturer, may be either less sensitive clinically, or you may be losing some patients. So what you could do is you try different cutoffs, and then with the assistance of the physicians, or if there's a cardiologist there, you guys can modify your cutoff compared to what the manufacturers originally indicated. So that those may be some ways that could be used to increase the sensitivity of a point of care troponin, and which are readily available. So that's just what I wanted to mention. Thank you very much.
Yeah. Thank you, Dr. Agbo. And 4 of you just stay in tune for this question. To you, Dr. Taka, before I bring in Dr. Valerie, whose hand has been up, permit me to ask this question. If you are given 10 million francs and that you make a decision whether to staff the 10 regional hospital with the machine that will do the troponin test, or to equip 30 district hospitals with ECG machine, which decision will you make? You have to unmute yourself, Dr. Taka.
Right, thank you. I'm sorry. It's going to be the EKG, and here's my reason why. I'm going to be a little bit technical here. So when we talk about heart attacks, you have, on the one hand, you have the STEMIs and you have the non-STEMIs. All right. Now, you do not need a troponin specifically if you're dealing with a STEMI, because the diagnosis of a STEMI is based on the symptoms and the EKG. This is very important. Now, with the N-STEMI, right, you could need the troponin and the rest, right? Now, why this distinction is important? Because the highest level of urgency comes with the STEMI. This is very important. We'll talk about door to balloon time, first contact, all those time limits. It only applies to the STEMI. Now, the other cases, the non-STEMIs, right? The non-STEMI heart attacks, I wouldn't even call them heart attacks, but the non-STEMIs, the ones where you have the partial blockages, for those who saw the pictures I showed, you can take your sweet time and get a troponin and trend up and down, because in that particular case, you may not necessarily see those ST segments elevated, but in a very specific context of the ST segment elevation, where you have the complete blockage, where it's an emergency, where you have to unblock this with thrombolytic therapy or with a stent as soon as possible. In that particular instance, all you need is an EKG that shows that the ST segments are elevated. All right. So I needed to make that distinction. And that's why in my mind, the EKG is still more critical than the troponin. Now, I should say that both of them are important. It's just that in the particular context of a STEMI, the EKG is critical. Matter of fact, we don't ask for troponins when patients come in with STEMIs. As soon as we see the EKG, we're rolling to the cath lab. No one waits for a troponin. It's for that exact reason. Okay, thank you.
Thank you. Now, Ndib, Valerie, your question, please. Valerie?
You're muted.
Valerie, we are unable to get Valerie. Please, can you unmute yourself? Okay.
Awesome.
How about you, Valerie?
Yeah, we still can hear you, Valerie.
Sorry, we cannot hear you. I'm sure there is a disconnection between your earset and your microphone. While Valerie is getting set to ask this question, Dr. Kate, may I bring you in by first of all asking you how much is the cost of, I know you are on the ground, you might have an idea, and how much is the cost of an ECG machine in Cameroon? Dr. Kate, please.
Thank you so much, Elvis, and really thank you, Taka, for that really brilliant presentation, and it's so nice to see you again. So the ECG machine, I think the standard one should cost about 2 million francs. I last checked some 2 years ago when I was interested in getting an ECG actually for narco purposes. Talking about NACO and ECGs, Dr. Sostani is here in Bafusam. All right. Well, I just really wanted to talk on something. Really, I was supposed to talk about building a body system, which I think Dr. Pat mentioned already in the chat. Because I think from a public health view, we cannot really delve towards trying to get all these recent technologies, but we can really focus on what works. And what works is will be actually furnishing our clinics and hospitals with ECG machines and actually training people to use them. And that comes back to the training issue. And just to say, in Cameroon, I hope many of you know there is a cult around ECG with cardiologists because it brings money in one way or the other. And we tend to forget that the ECG is not a paraclinical exam per se. It should be actually part of a normal clinical evaluation of a patient, especially for a patient who is going to present with chest pain. And so when we are talking about this discussion, we should start about how do we break this cord, this cardiology ECG cord, and for people to know in Cameroon that ECG, medical students, medical doctors, GPs are really supposed to be trained to know how to use the ECG in the hospitals. So I think Taka tried to simplify this. We need ECGs. And I'm just trying to say we need to really get out of the court and make every medical doctor, medical students, GPs all over the country learn how to use the ECG and to identify some of the things Taka was talking about.
And Dr. Kate, before Dr. Taka comes in, you're back in Cameroon. Ever since you left school and you've been practicing, has there been any moment where you felt like taking a certification like ACLS, maybe to improve on your knowledge on cardiology and basic life support certification? Is there a standard like that in Cameroon where people are expected to have it as part and parcel of ongoing certification?
Yeah. So for me particularly, I did not take the certification exam. But I was trained in the basic life support and the ACLS after that. Well, in South Africa, I think that was just when I graduated. But I think the Dean of the Faculty of Medicine in Yaoundé some few years back had started the program for the training in basic life support and advanced cardiovascular life support in Yaoundé. And they were actually issuing certifications at the end of that training. But it seems that has stopped, unfortunately. I really have no idea if it's continuing. So, and that is something we really need to talk more about for people to learn and for young medical graduates, for GPs to really know that these things happen and that they can actually subscribe to get this kind of training, which is useful.
Yes, over to you, Dr. Taka. He says that not only getting the ECG machines, but actually ensuring that there is appropriate training. And we just talked about BLS and ACLS. What can we do to improve on this training?
So I don't know if I'm the right person to ask that question to, because I was actually hoping that Dr. Kate would give us granular details on how this can be done. I think I agree with Kate 100%. You have to make the machines available, but also you have to ensure that the physicians on the ground know how to use them. Both are equally important. Exactly how this is going to happen would always start with affordability and willingness. I am not surprised that there's this whole concept of a cult around amongst cardiologists in Cameroon. I mean, like in many other things, like back in the day, it used to be the CT scan, it used to be the MRI. You couldn't get into any of those things because people had their quote unquote narco around those machines and all of that. I think it's going to take a lot of education. I think some of us, myself included, I feel responsible in a way for contributing directly to this education in Cameroon. You know, I've talked about this with a few of my other colleagues who are cardiologists in the United States here about doing correspondence programs with medical students and faculty about training people and even making this equipment available. I kid you not. You know, there are so many companies and there are so many hospitals who are willing to shed off their EKG machines, right? You've got this EKG because what happens is technology evolves so fast that the EKG machine they had 5 years ago, they're switching over to a new EKG machine. And you have all this equipment here that we don't even have in Cameroon, you know? So we do have the equipment that can be made available. I think we do have the expertise. I'm not the only, Sostane was here. Okay, Sostane is still there. And I think we all know ourselves, and I think we can collectively at some point be of use. You know, go back and try to educate people on how to use this equipment.
Right.
From my standpoint, I don't know about the people on the ground, but
no, that's a good idea. Muno and I had this conversation, and I'm glad you're thinking about this, and that could become the next town hall project. We wanted to see how we can have some open source, resources for training like this, where experts like you and your colleagues could do some kind of, presentations and education that can be hosted on an open source that can be used by our brothers and sisters back home to upgrade their knowledge. So I hope we would be able to have another conversation on how we can harness all the expertise through the town hall to see how to make this work back home. So thank you very much. We now have Valerie. I'm sure you have been able to handle the microphone problem. Valerie, over to you.
Thank you very much, and I apologize for the technical issue. Thank you very much, Dr. Taka, for your presentation. I really enjoyed it, most especially because of my interest in cardiology and especially interventional cardiology. I'm a clinical epidemiologist, so when I saw the title of the presentation, it really interested me because this is a huge topic for debate in the academic media at present. So my question to you after this presentation is, do you think ischemic heart disease or coronary heart disease is a problem in Cameroon? Now, the problem is some of the data that you presented are mostly data from the global burden of disease. And we know that these are modeling data. And there are a lot of concerns that this particular data might be an overestimation of what we are seeing on the ground. Because we expect that the prevalence of coronary heart disease should increase because we are seeing increasing prevalences of the risk factors of cardiovascular diseases like hypertension, diabetes, obesity, all of those things are going on. And so when the global burden of disease takes all of this into consideration, it actually estimates that coronary heart disease should be responsible for about 5% of all deaths that we are seeing in Africa and up to 40% of all the cardiovascular deaths. But this is not what we are seeing on the field. If you go to the field and you try, there are data on the field, data from Nigeria, data from Uganda, you see that ischemic heart disease is actually less than 10% of all the admissions into medical units in Africa. So the data that they are presenting, the global burden of disease is presenting, and what we are seeing is different. Now, here's a big question which you highlighted and you have discovered. We have spent a lot of time talking about it. Is it a problem with the diagnosis, which we are sure that is a problem with the diagnosis? We are on the ground. We have worked in these hospitals. We know that the tools are not present. So we know that we have limited biomarkers, we have limited ECGs, especially in the rural settings. And even in the urban settings, is some limited facilities that actually have this capacity to diagnose. I don't think the problem is the algorithm. I don't think the problem is being able to identify that patient where you should do an ECG. Because these have been taught in schools. We were taught this in school. And if you pass through your internal medicine rotation, coronary heart disease or ischemic heart disease should be one of the things you should know. And even if you don't know how to read the ECG, it will tell you that, okay, this is how you diagnose SC segment elevation or SC segment depression. Those are the things that we learn them in schools. We've been taught in school. But the problem is the capacity to diagnose these things. So my question is, before investing, I want us to invest to build capacity in diagnosing coronary heart disease. But we have a lot of problems in Africa. We have a lot of problems in Cameroon, and we have to prioritize as the economists will say. So my question to you is that, is coronary heart disease a problem? Is it a hidden pandemic, as is written on the title? Do you think it's a problem? It's not a problem.
Thank you, Valerie, for your question. That's a very good question. You know, yeah, absolutely, it's a problem. And I like how you talked about being on the ground and not seeing these cases. In fact, that's the core of my presentation, and that's what bothers me. The fact that there are a lot of physicians on the ground who are not usually poised to do EKGs, and by so doing, they miss a bunch of these patients who come in with heart attacks, you know, or ischemic heart disease. So there is no reason I can think of in my mind. Of course, granted, we don't actually have solid granular informed data in Cameroon. There is none. And that's just additional proof that we are probably not diagnosing them. You see, that slide I showed from April 2020, it shows cardiovascular disease and does not provide any information on ischemic heart disease, you know. And I've spoken to a bunch of clinicians in Cameroon, and it comes back to the same problem. You cannot know what you can't see, and vice versa. You know, that's the problem. Now, what I can tell you is that the prevalence of ischemic heart disease in Cameroon is not 0%. That's for sure. Now, whether or not it's a problem, I don't expect it not to be a problem. You know, I don't have data from Cameroon to back that up, but we need a point to start off from. So you cannot assume, so this is kind of interesting. You cannot assume that is not a problem if you are not diagnosing it in the first place. So make the diagnosis, identify how much of a problem it is, then decide how much of your resources you want to dedicate towards treating it, right? So I think that's the first step. We actually have to make a diagnosis. Ethically speaking, logically speaking, scientifically speaking, it starts with making a diagnosis. So I think that's the first step, and that's why we're having this discussion today.
So to add to what Taka just said, I'm an epidemiologist too. There's a fallacy in epidemiology that when you don't see something, it means it's not existing. And it's a big fallacy in Africa, because I will tell you, back in the 60s, there was no hypertension in Africa. It was documented in all your books. Is it because there was no hypertension? No one was testing blood pressures. Back in Africa, there was no diabetes. Is it just because we're having a second epidemic of diabetes? No, my grandfather died of diabetes. It's because no one was testing it. He had diabetes in the 80s. So when you don't test something, you don't see it. If you don't train, I know you were trained to see or learn about heart attacks, but you cannot be in a hospital like La Cantini where there is no EKG in the emergency. In the regional hospital in Bamenda where there is no EKG in the casualty. In the regional hospital in Boya where there is no EKG in the casualty. In Limbe, same thing. All over the Republic. Just recently in L'Hôpital General, I had an aunt who went to the emergency and had COVID. We wanted to do an EKG. The EKG was hidden in the office, in the cardiologist's office. So you are living there is a fallacy in Cameroon, even when you're an epidemiologist, that these diseases don't exist because you are not testing them in the right places. They are not supposed to be in the cardiologist's office. So you are never going to see a STEMI in a cardiologist's office because nobody comes to a cardiologist's office with acute heart pain to get an EKG. So in order for you to diagnose a heart attack, you need to put these machines in the right setting. I told you I worked in CSU as a pathologist. we did no troponin on any patient when I was there. Do you know why? No internist they are trained to understand heart attack exists, but it's in a book somewhere. Nobody in CISU emergency ever thought this was a heart attack and sent for a troponin. One way or the other, they thought it was not going to be done that night, and that's true. So if you've never worked in all these settings and had this, we all worked in Cameroon, and you have the pleasure of reflecting about your practice. How many patients came with chest pain when I was working in Bamenda? How many of them came with GERD? My dad died of sudden death, and he went to Bamenda. Nobody did an EKG, neither nobody even drew a troponin. He left the house crying of this and died in the hospital. These are things you can never say they don't exist because you did not test them. This is in the US and other African countries, Blacks are dying of heart attack more than white. It's been documented. Our level of obesity is increasing. These are very important points where is this fallacy in epidemiology where you say, I don't see something, so it does not exist. It's bad, you don't test it. You cannot, Taka made it very clear with the illustration of the king who had no dress. That is how we are. We are that king in Cameroon with no dress. I don't know if Dr. Sostani has a reflection about this particular thing. You're a cardiologist and you worked in Cameroon too.
Yeah, I think I'd like to chip in on this point because it's important. I know diagnosis is a problem, but if you look at our non-communicable diseases, non-communicable disease is a problem, right? And a lot of our retrospective data, not very optimal, shows that hypertension is a problem. We know that diabetes is a problem. If you have all of these cardiovascular risk factors, there is no way you will not end up with coronary artery disease and heart attacks. So I just come to join everybody to say it's a problem we don't look at because we don't diagnose, we don't identify. I'm really impressed to hear from Valerie that these things are really taught in internal medicine because it was a conversation. These conversations were not had when we were in QS. I think everybody here was my generation in QS. So if things have really changed over time and you say these are conversations which are had in QS, I'm really impressed. We didn't talk about heart attacks a lot because it was not a conversation. It was not the problems we saw every day because the patients who were admitted to CSU were not patients who had a heart attack. Either some of these patients were not diagnosed or some of them just died because the diagnosis wasn't made. But it wasn't really a diagnosis for a lot of I want someone here to challenge me who was in our period in QS that's different. It was not a diagnosis on a regular day when you walk into a busy internal medicine floor in Central Hospital or in CSU. So I think it's underdiagnosed. I think I support the fact that education has to begin, and I think it has to begin from our medical school, our medical students. I would like to support and join anyone to be part of this capacity building of a series of educational lectures to teach these patients a little bit of EKG. And I think over time we will solve this problem. It's not something we'll change in a day, but I would like to be part of that gesture. And just to conclude, if risk factors are present, that diagnosis is not there because we don't have the ability to diagnose it. That's why it's not recorded.
Thank you so much, Dr. Sostani, for coming in. I really appreciate it.
Thank you, Dr. Fuman.
Yeah, thanks so much. And
Yeah, I mean, before I give the floor to my good friend Donald Chapman to ask this question, I think the dynamics are kind of changing in terms of the epidemiology of non-communicable diseases. Thinking more, I think Valerie asked a really profound question, and it brings me back to the root causes of heart attacks, even in the United States where we have very good data. And I think disproportionately, Taka shared a slide that Blacks were more disproportionately affected than whites or other groups. But the social determinants of health, something that we don't talk a lot about, and these socioeconomic factors and stressors and all the factors that really drive the rates of cardiovascular diseases. And the dynamics is changing in Africa. It's not the same problems that we face, the Black American faces, like issues around, not having access to good food, eating fast food and hamburgers and pizzas and things like that. That's kind of beginning to change. So, and Valerie asked this question around predictive models that we use for the developed world and trying to use those same predictive models in Africa, and it's really not the same. But I think one of the things that we're really looking into is what are the root causes of cardiovascular heart attack? What are the root causes of this? And do we have those risk factors prevalent? I mean, what's the rate at which those, risk factors are kind of beginning to, rise in our own context, right? And that would tell us if we are missing something, right? Are there some blind spots? Are there some things that, that was just a quick comment. Chapman Donald.
Okay, good evening or good morning. I don't know what time it is there. Oh, good afternoon. I hope you can get me well. Yeah, I'm sorry, Brian, I cannot put on my camera because I don't have light here. I'm in the dark. So just wanted to add some comments concerning the presentation. So thank you, Dr. Taka, for the presentation. It was very interesting. I just want to add some few stuff concerning Cameroon. So it's very important to note that, first of all, in medical school, we were taught about heart attack. We were taught about myocardial infarction, STEMI, non-STEMI, how to identify them, and so on. The thing is that during internships, we have very few cases. And when you don't manage a case in medicine, you tend to forget very fast. That's the issue. In internal medicine, for example, I had just one case that I saw in my internal medicine internship when I was in the 4th year. And it was obvious. He had all the signs and symptoms. ECG was clear, it was STEMI. But though we could not do anything apart from beta blockers, oxygen, morphine, there was nothing else that we could do. So it was in general of Yahoo. So we thought about it. The problem is that it's not very frequent. Maybe because we don't diagnose it, maybe, but it's not very frequent. Now, I've worked in Curie for some time. After graduation in 2017, I worked in Curie. I was there mainly in the research department. I was not in the clinical floor. So we were mainly doing research with, because the Koreans are the ones that sponsor the bid to open the Curie, which is a Yaoundé Emergency Center. It is a reference center in Yaoundé for emergencies. They manage strokes, they manage myocardial infarction and other emergencies. So there in Curie, what we do is that there they do this thrombolysis using alteplase. They do it in Curie. So when a patient comes in with chest pain, they do the EKG, they see it's a STEMI, they push the alteplase to do the thrombolysis. So it's done in Curie in Yaoundé. And the physicians there are trained on how to diagnose the STEMI. The physicians and even the nurses are regularly trained in Curie on CPR, on basic life support. And the physicians are trained on advanced cardiac life support. That is because the Koreans are there and they try to implement this system where the protocols are well respected. They try to respect the timing, that is from door to thrombolysis. So all of that is known, and it can be done with just a bit of will. We can do it. We can improve things. So it's done, but we're in Cameroon, and we should not forget that here there's a very important issue of the cost. Do you know how much it costs at a place in Cameroon, Brian? Any idea of the cost? No idea. So a patient comes in query, for example, has chest pain. We do an ECG, it shows he has STEMI. Now we say, okay, we need to do thrombolysis. One via, Arteplase is 1.5 million CFA francs. 1.5 million. How many Cameroonians can afford that? Imagine you are working there, you are fine, you are just fine, and then you just have acute chest pain, and you go to hospital, you need to give 1.5 million now. How many can afford that? So that's a big issue also in our context. So that's why it's also a problem. Now, I have to take an example of Yaoundé BMRC Hospital that's concerning the ECG. In the BMRC Hospital of Yaoundé, the director there is a cardiologist. So the director said there that any patient that comes to the emergency unit with chest pain or epigastric pain, age more than this, should have an ECG done. So that's why he said. And he wrote the note and pasted it in the hospital. Any patient in the emergency unit comes with chest pain or epigastric pain, age more than this, should have an ECG done. People were like, he's doing it for his narco because he's a cardiologist. He wants to eat people's money. That's why he's prescribing that. But it is very normal. Many people come with just some kind of epigastric pain, and we think it's gastritis or peptic ulcer, and we'll give omeprazole and send them back home. But many of them might have a myocardial infarction. So he said this should be done, but people were like, no, he's doing it to have his own money behind the patients. And people were not really in favor of that his decision. So you see how our mentality is till now. So having said all that, the protocols are well known. I believe Cameroonian physicians can diagnose myocardial infarction, and even if necessary, they can treat it. The problem is that we don't have the means to diagnose always, and even the means to treat it, we don't have. Currently, I work in a rural area in Cameroon. It is in Gelmenduka. For those who know Gelmenduka, it's in the east region of Cameroon. So there in Gelmenduka, if I see a patient today that has chest pain, and I suspect a myocardial infarction, what will I do? I will put aspirin. It's an acute phase. I'll put aspirin. I'll put tramadol. We don't have morphine in Gelmenduka. I'll put oxygen, maybe a beta blocker. And then I will pray that he does not develop any complication. And then that's all. And then I might counsel the patient that you might go to Yaoundé or Betua to do an EKG and heart ultrasound, they say cardiologist, Many of them will say they don't have the money. They don't have the money. But money is a big issue in our context. Talk about troponins. Yes, we can have it, but how many patients will be able to afford the troponin? In Gelmenduka where I work. So that's the issue. There's issue of cost. ECG machine is 2 million, like Kate said. And also, this reminds me of this Cameroonian who developed what we call the cardiopad. I think you've heard about it. The cardiopad is an ECG machine that is actually portable. It gives you the ECG tracing on a tablet. So the cardiopad was offered to our hospital, actually, to Gelmenduka GC Hospital. But the nurse who went to Betua to take it was, how do you say in English? Anyhow, the thieves took the cardiopad away. So he misplaced it. So we don't have any cardiopad in Gelmenduka now. But that's the thing though. But the machine is expensive, and a patient who has an MI or a STEMI, to be more precise, thrombolysis is 1.5 million to get that. So it's not easy. So that's just it. But I think physicians can diagnose myocardial infarction in our context. I think they have the knowledge, and if necessary, if we just need to train them and remind them that, hey, think about this if you see a patient with this, and I think we can do it. So thank you. That was just my intervention. Thank you.
Thank you so much, Donald. Maybe some words from Sostani and Taka, now that thieves are stealing ECGs.
So, well, Donald, thank you so much. That's the kind of perspective that we need here. So, first of all, Arteplase, Tenecteplase, urokinase, all of that, it shouldn't cost 1.5 million. Straight up, I'll just say that straight up. Multiple reasons why. First of all, assuming that it's a medicine which is not in every government hospital, just that, assuming that, I do have an idea of how much this should cost in the global market. So except if you have, and I suspect this is what's happening, I suspect that the medicine, I may be wrong, correct me, I suspect that the medicine is not available in the government hospital. And so there are private pharmacies who would sell that medicine for 1.5 million. I suspect that that's the case. Now, but that shouldn't be the case. You know, it's a medicine that should not cost that much. Now, that aside, I think that, and I think when you spoke, it got me thinking. I think we may have to think of a more inclusive approach, especially when it comes to giving thrombolysis in these patients. Whether or not this is something that has to involve the government and government policy, I don't know. This is just a thought I'm throwing out there. Now, the assumption that every clinician is comfortable making a STEMI in Cameroon, I think it's a little bit of a stretch. I mean, even in the United States, we have challenges having people diagnose STEMIs. Of course, aside the obvious bread and butter STEMIs, there are cases that even at my hospital, our ER physicians miss. So there's obviously a lot of work that has to go into training people in Cameroon and in many places in the United States as well on how to diagnose STEMIs on EKGs. But I understand that getting an EKG machine is expensive. I guess the question is whether a patient's life is worth, or many patients' life is worth 2 million francs. If I had a private clinic in Cameroon, I would get an EKG machine, just because I know, for two reasons, even purely from a business perspective, right? Which is not the reason why I do what I do, but I think getting a machine for 2 million francs and using it appropriately will more than pay for itself. I don't believe, if you told me an EKG was 100 million, I would understand, but 2 million really. Again, I understand you're probably in a government hospital. The challenges are a little different. And for cases like this, we might have to involve the government one way or the other. I mean, I don't know if any other person has comments, but that was my 2 cents.
Oh, unmute yourself, Sostene. After that, I have a comment.
Thank you, Donald, for that important adjunct. And I'll see you in New York in a few weeks, if you're not here already. This TPA is a very good alternative. I think it will be a very good alternative, especially for our context, where cath labs are not very developed, if the patients meet the criteria. Cost-wise, it sounds very, very, very expensive from what Donald said. I didn't think about that to be millions, because I know I was part of a program for Ghana and Nigeria. I have an interventional, actually it's an electrophysiology guy who goes to Ghana and Nigeria and does these procedures. And I have some insight, not Cameroon context, but in these other regional countries around us. And it didn't sound like $1 million francs, it doesn't even sound like $1 million naira for out of place. So that's why I'm a little bit, if to me, if this is a problem we're trying to develop, if this is a program we're trying to build, a problem we're trying to solve, I like to look at the solutions, right? I think an easier solution to this problem is capacity building and involving the government to even invest in TPS, out of place, connect a place, than to build a cath lab. I think it will be cheaper than investing in building cath labs all over the country, Cameroon. Cost-wise, I think it's open for discussion. It will be cheap. It will be expensive for the patients who need government subvention and government intervention to make it more available for the patient. That's just what I wanted to say.
Yeah, so I want to add, Donald actually highlighted a point which is important in epidemiology. So Donald said, as other Cameroonians usually say, it's not a problem because they are not diagnosing it. But when they created Curie, they started having cases because the Koreans were there and they were looking for it. And they started giving patients after place. So cases have been diagnosed because a center has been created in Yaoundé where people are coming and someone is actually looking for it. This tells you in epidemiology that truly, if you have a system in place where you're looking for something, you start seeing them. If you are not looking for something, I know in his initial statement, he said they are looking for it, but in Golomenduka, where you are, if there's no EKG, you will miss the patients who come in with mild chest pain, looking like GERD. You will miss majority of the NSTEMIs who are existing, who come around. You're going to miss them because you don't have the facility to, or the adequacy to diagnose them. The person you want to diagnose is the STEMI patient who may have died at home because we're not used to coming to the hospital. So you don't see the majority of them die at home. So this is very important in epidemiology to look at the lag time, those who die at home. And I know we're talking about epidemiology of cardiovascular diseases, the rise of diabetes in Cameroon. As Brian was asking, there is a rise of diabetes. I know Kate works in diabetes. There is a rise of hypertension in Cameroon, especially. Those are the two big factors that you look at when you're talking about cardiovascular diseases. We all know they are rising back home. They are not getting better. As I told you, my dad had a heart attack, and many other people do have that. So once you created a center of excellence, you started seeing cases, which right now I know is no longer functioning the way it was functioning since the Koreans left it in the hands of Cameroonians. So it's some other discussion of another day. But in the podium, I see other people. There is Clarence Ipong, who maybe will give him a time sometime. He's a cardiovascular surgeon, cardiothoracic surgeon in Germany. So there are other people who are here. I know there are many hands that are up. Elvis, over to you.
Yeah, thank you so much. We've been together already for almost 2 hours or 20 minutes. As we are looking at wrapping up, I'll give the opportunity to all those whose hands are up now to ask their questions. Please keep your questions very brief, just so we can have the opportunity to have all the questions asked before we wrap up the session. And at this point, I want to bring in Fomukong before we bring in Dr. Clarence. Fomukong's hands have been up. Can we hear your question, please?
Hi, everyone. My name is Dr. Fomukong. I'm a physician in Georgia. I don't really have a question. And thank you, Dr. Taka, for that beautiful presentation. Are we sensitizing the public on what they should look out for? That is my goal. Are we telling our family members chest pain doesn't just mean you're lifting something heavy? Are we always brushing them off? When they call us, when they tell us about your chest pains, what are we teaching the public? Are we sensitizing them enough for them to go in when they have these chest pains? It's not about GERD all the time. It's not about, costochondritis all the time. There's more to it than meets the eye. Are we doing what we're supposed to do with family members, with friends, with churches, to make sure that they get the help they need? And again, everyone on the forum, I guess, is a good media for us to have access to each other. There was, I think, Dr. Donald, he was talking about what if he has an EKG. You have Dr. Taka on your team. You have lots of other people here. All you need to do is shoot an email, shoot a text. That's what I do with Dr. Taka all the time. I mess his life up all the time. Take a text, take a picture of whatever you have and say, hey, this is what I have in front of me. There is no trophy. One life saved is one life too many. So let's all be in this whole thing together and save lives. Thank you.
Thank you so much, Dr. Fomukong. And that reminds me of something I wanted to say. We said we really have underdiagnosis when it comes to heart attacks, but I think the community is diagnosing it more than the doctors, because I hear this all the time. He died in a heart attack, yeah. He died in a heart attack, yeah. Like all the time somebody dies in the quarter, they say it's heart attack, it's heart attack. Is it a kind of community diagnosis that is more than medical diagnosis? Because I think people know a lot that when somebody drops dead, it is heart attack. So I think it is important to what you just said. We should educate our friends, our brothers and sisters on this as well. So maybe we bring in Dr. Clarence now to give us some thoughts on this.
Thanks, Taka, for the wonderful presentation. I'm Clarence Pimpo. I'm a surgeon in Germany. And Muno, thanks too for this platform to be able to share our ideas. I just have a question. We've been talking all the while about acute myocardial infarction. I think prevention is actually cheaper than thinking about the price to pay. I don't know, I missed a big part of Taka's presentation before, but I'm actually thinking if the surgeons were trained to identify the risk factors, like Muno said, diabetes, hypertension, the treatment of these risk factors are way cheaper than receiving the patient in the emergency room. So how is the situation actually in Cameroon? And a question to you, Taka or Muno. Now we've identified the problem. So what do we do about it? Do we discuss about it again, maybe sometime next year? Or do we get practical? Thanks.
So let me respond to this, my dear friend Clarence. So you know, Clarence, you remember several years ago when I was in Cameroon and you were so enthused about coming to change things in Cameroon. And at the time you were a medical student in Germany. You know, I'm with you on that. I think we have to take the lead on this. I think it should not only be about talk. I already started talking to a few people here, and I know you've been doing a lot of work in the background. You actually wanted to go to Shisong. We've had this discussion before. I think this platform just reinforces the need for us to collectively put our hands together and try to make a change in a practical and a meaningful way, so we don't keep going around in circles. You know, about the prevention, I sort of brushed on that a little bit towards the end of my presentation without going too much in detail. Yes, I think preventive medicine is not too well established in Cameroon. I think I talked about the exercise stress test, which I personally think is very critical in long-term prognosis for acute coronary syndromes, and it's also quite affordable. So I kind of mentioned that at the end, but I think those are things that we can expand on. Definitely.
To add on what Taka said, the platform really, we are building capacity. That's the first thing. We are planning to extend with education, and we'll need everyone available here. I just got to know Dr. Mafri. We're going to, including you as a cardiothoracic surgeon, to be able to get back home, train students who are in training, those who are students who are still medical students, to have this level of suspicion, to also get to advocate so that their hospitals could have these basic tools and let them be available in the places where they have to be. Because you can have an EKG in a hospital, if it's not available in the emergency unit, then it's not worth it. That's really where the message is coming. If you don't do it where it's supposed to be, if it's found in a cardiologist's office, that's where you will never see these cases, because you just have the right instrument in the wrong place. So you do EKGs that will all be normal. And I'm saying this from an epidemiological point of view as an epidemiologist also, not really as an internist or an endocrinologist, and as a hematologist. But if it's found in the right place at the right time, then we'll get this diagnosis. So the platform is to, first of all, discuss problems, which we are discussing right now, and not to come each time to defend situations, because if Nigeria is getting heart attacks and diagnosing them and treating them, and they are our neighbors, then Cameroon there is something wrong. And as Dr. Marfree said, there is education that has to go in the community. Where people have chest pains, they should go to the hospital. Once they get to the hospital, they should not be pushed aside. They should be able to have the right test. Not everybody who comes to the hospital should get a malaria and typhoid test. It should not be that my typhoid all the time. Like you see, someone falls dead with that my typhoid for the past 10 years. He has never had anything advanced going forward. So it's very important for us not to take training and end with it in the hospital or end with it in our bedrooms. Take the training out there and try to start suspecting that these things truly exist. And if there's no protocol in place, we'll miss all of these things.
Thank you very much, Muno. And at this point, we'll bring in Evelyn, whose hand has been up. And I think Evelyn will be our last person to ask a question. Then we'll give the floor to Dr. Taka and Dr. Clarence to give some last words and closing remarks before we wrap up the session.
Thank you so much for having me. I come into this forum not as an internist or a medical doctor. I'm actually a pharmacist and a pharmacologist. So just listening to you guys talking, I'm going to be quite general, not so specific as you guys have been. The thing with environment is very, very important. The mindset of a people is also very important. We are coming here from point of view of those who have actually studied all of these things. Remember that, you know, we have things that are embedded in us. So first thing, we have to have education. The medical board in Cameroon needs to step up. They need to do what they have to do. Educate, educate, educate the public. Once they're educated, the doctors also, the training should be continuous. For those of us that are out here, we have continuous education. In Cameroon, I don't think they do. You may talk of putting an EKG there. What is the point of an EKG if you cannot really read what it says? You go to school, you come out and you're a doctor and you carry it as a gallon, and you don't do what it takes for you to get educated. So please, doctors should do training. I thank the last speaker for saying that training should also continue. It should start from the schools. Yes, those of us who are out here should actually impart. Take your knowledge over there. Have some time to go there and help in teaching. I wish the government can do that so that those of you that are out here, take some time, go back into Cameroon and teach them. That way, that is what continuous education, and also have them come over here and learn something. EKGs. We live in a country where the technology is changing. As it changes, these instruments are out there and they are even thrown away. We can use them. So please, me just sitting and listening, we can use those things. We have the capacity to be able to go to some of these hospitals. Doctors, hey, Dr. Taka, you should be able to do that. Dr. Mafri, you people should be able to do that. Get these instruments out there. So I'm just being a bit general because I'm a pharmacologist and a pharmacist. But on the other hand, try to institute a protocol. Somebody has high blood pressure, somebody has diabetes. You guys know in the protocol over here, automatically, you know, they have tests and they should be on some statins or something to help them with cholesterol, which is also a preventive measure. So please let us look at prevention and all some of the issues that are raised up. Thank you all. It's so nice that there is a forum like this. Thank you.
Thank you so much, Evelyn. Thank you for your generosity in trying to see how we can collectively solve this problem. I think if you attended a town hall today, you come from a certain village in Cameroon, you should be thinking of what to do at an individual level to donate an ECG to your health center in your village. That should be a personal commitment if you want to start doing something. We all need these ECGs in our different health centers in our villages. Okay, so at this point in time, ladies and gentlemen, thank you so much for being part of this session. I'll be giving the floor to Dr. Clarence. I put you, don't leave, you are still on spot there. Maybe you want to say one word before Dr. Taka takes it off to give closing remarks on this topic. Dr. Clarence?
All right, yeah, good. Thanks one more. I would just like to add to what I had suggested before, because patients don't only die of acute myocardial infarction when they come to the emergency room. There are other leading cardiac problems which could be solved through timely surgery. So cardiac surgery could be another topic to talk about the situation of cardiac surgery in Cameroon. So maybe on another occasion, if Dr. Muno should give me the possibility, maybe we could highlight the situation of cardiac surgery in Cameroon and try to discuss about acquired structural heart diseases in Cameroon. So I'll be willing to talk or to help or to highlight the situation if Muno should give me the chance.
Yeah, Clarence, you have the floor, please. I'm proud that my classmates are stepping up. So I'm very proud of this. So we're going to give you the chance. I think Elvis, Christelle, and Solange and Alison, they'll get back to you. We'll give you give you able time to prepare so that we can get to understand this very well.
Okay, because I think many people are dying too of diseases which could be prevented through timely surgery, and maybe we wouldn't see these patients at the emergency room if they were treated or diagnosed and treated well ahead of time.
Great.
Okay. Yeah.
Thank you so much. And now we'll give the floor to Dr. Taka to wrap up your presentation and give us some words of hope.
So this did not feel like 3 hours or 2 hours, 30 minutes. Thank you all for being very engaging. I would wrap up by saying that I'm very open to working with as many people as possible. Muno knows that there's another topic which I am very passionate about talking. Mafri knows that as well. It's about amputations in Cameroon, the amputation epidemic in Cameroon. But these are things that hopefully, as we talk about them, I'll be able to get support from each and every one of you on this forum in order to make effective and impactful changes back home. And of course, I'm acknowledging the help of all our physicians in Cameroon as well. I think we need to put our heads together and make meaningful and impactful changes so that our parents and our relatives are better taken care of in Cameroon. So again, I'm going to make my email available. Some of these projects that we're looking at, you all are invited to join. Thank you so much.
Thank you so much, Dr. Taka. Thank you for your time. I would hand the floor to Dr. Solange Bama. Vous avez quelque chose pour la conclusion de cette session? Dr. Solange Bama. If not, Christelle, take it away from me.
If Solange is not there, let me just back up rapidly. Merci beaucoup à chaque participant. Merci pour les présentations. Merci, Dr. Taka, et merci à chacun d'avoir intervenu. Et rendez-vous à la prochaine saison de Cameroon Town Hall.
Merci beaucoup, Christelle. Thank you so much. And Brian, take over.
Well, thanks, everyone. I think it was a very engaging conversation, interesting conversation. Just wanted to highlight that there's a parking lot after this, so stay on.
Yeah, thank you very much, Brian. And Louisa, you were about to sign off for an important engagement. Are you still there? Louisa?
Hi, everyone. Sorry. Sorry, Elvis, I had to go.
Oh, great.
Thank you so much, Dr. Kata, for the talk. It was really nice listening to you. And see you all next 2 weeks. Thanks.
All right. Thank you so much, ladies and gentlemen, for being part of this session of the Cameroon Town Hall for Healthcare Professionals. It was really an interesting session talking about heart attack, questioning if it's a hidden pandemic in Cameroon. We want to really say many thanks to our expert, Dr. Nchang Taka, for his sacrifice of time and also for the very insightful presentation, which he has served us with this today. We shall be meeting again in a fortnight to have another conversation still on another very interesting topic that concerns the health of our people back in Cameroon. Of course, we want to always thank all our co-moderators for moderating this session. We encourage our French-speaking doctors to come up and present also in French. And we also hope that we are going to continuously try our best to make this platform as bilingual as possible. Thank you, Dr. Muno Kenneth, for your leadership. Thank you for always putting this together. And I want to take this opportunity to say, if you are able to stay in the parking lot, feel free to stay. And that's where we do a lot of networking and exchange of contacts to build connections and platforms across our network.